Bismillah Rahman Rahim. I am Professor Dr. Iqbal Afridi, the Dean of the Jinnah Postgraduate Medical Center and Jinnah Sindh Medical University. Rabbi Shrali Sadri Waisirli Amri Walalugdatam Milisani Yafko Qawli Sadaqallahu Azim. We are talking on a very sensitive topic, that is male and female sexual and reproductive dysfunctions. The WHO Program for Reproductive Health identified that the men in South Asia face following challenges. First of all, men do not possess sufficient information, and therefore they really face a lot of problem related to sex and reproductive health. And men are at risk of reproductive health problem. They also have lack of interest on the part of men in the region in their partner reproductive health, because they shy to talk about the spouse sex related issues, and men are marginalized by sexual and reproductive health services. Especially I have observed that the doctors or the medical community is also having face problem while assessing or treating such patient. Most men do not actually accompany their partner for family planning and antenatal care consultation during labor and delivery. And therefore, the partner notification and treatment of sexually transmitted diseases are difficult, and they lead to a lot of complication in the form of sexually transmitted diseases in men and women. Therefore, we should know about the normal sexual behavior. The normal sexual behavior achieves three major functions. One is procreation, that is reproduction, and there is it's also having pleasure component or gratification, and then there is a object of relationship, that is an expression of relatedness, and therefore they lead to preserve bonds between human being, leading to mature family, which is most important. The normal sexual behavior response is true psychophysiological experience. That means there is psychological component and there is physiological component in the form of relationship with the biochemical aspect, that is hormonal aspect, and there is arousal and experience of tension followed by orgasm, that is the gratification. The four phases responsible cycles in relation to stimulations are: number one, the first phase is desire, and then the second phase is excitement, the third is orgasm, and the fourth is resolution. The sexuality is not only determined by one factor, but it involves the anatomy, the biochemistry, the physiology, the psychology, and sociology, because the culture in which person lives, the relationship with others, and the developmental experience throughout the life is actually a determinant of sexuality. If you look at the dimension of sex, the male versus female, if you look at the chromosomal dimension, apart from the 22 pairs of autosome, the man has one pair comprising of X and Y, while the female has, as you know, that X-axis. If you look at the gonadal component, the man has testes versus the female has ovaries. And the hormones, the man has androgens while the female has estrogens. Similarly, if you look at the genitalia, apart from penis and scrotum, the women has clitoris, labia, and so on. The internal accessory organs include prostate, seminal vesicle, while in female, vagina and uterus. The secondary sex characters, the man has low pitch voice and they have beard, while the female has breast and menstruation. The sexual orientation, that is the heterosexual component, the gay and the bisexual component, while in the female, apart from heterosexuality, lesbianism and bisexuality is there. The gender identity is where the men perceive themselves as a male while the female perceive them as female, and the gender role in the male is masculine while the female is feminine. The gender identity is self-defined while the gender role is defined by the society, the social aspect. And one should also know that sex is a biological component connotation, while the gender is the societal connotation of human being. The human sexual response, there are five. First, mapped by the researcher Marston and his wife Virginia Johnson. The human sexual response can be described as a cycle with four stages. The first stage is excitement, that beginning with the sexual arousal. Then the second phase is plateau, that increases physical arousal. The third stage is orgasm, where the male ejaculates while the female vaginal contraction occurs. The fourth stage is resolution, or arousal subsides. There are myths, especially in this part of the world. For example, myths related to male sexuality. People consider that men feel like sex all the time, and they also feel that real men perform sex, while the men can have other good things as well. The respectable people should not enjoy sex and certainly never masturbate. This is also a myth. The man should be a sexual leader. This is also a myth, and real men do not have a sexual problem. Everybody can have, and men is not an exception. The misconception about the size, shape, and thickness of the organ is a lot of students and youngsters in our country, they have this misconception, and there is misconception regarding sexual intercourse. They consider that just intercourse is a component of sexuality and foreplay is usually ignored. The myth about female sexuality is that they think that women should not initiate sex. Sex is only for women under 30. And the other myth is pregnancy and delivery reduces women's responsiveness. And if women cannot have an orgasm quickly and easily, there is something wrong with her. These all are myths, and there is no scientific basis for them. Looking at the epidemiology of the sexual dysfunction in male, you can see that 17% of the male has lack of sexual desire in the last 1 month, while 2% of them in the last 6 months. And this is followed by premature orgasm that was noticed in 12% of the men during the last 1 month and 3% during the last 6 months. If you look at the female side, the 40% of the women had lack of sexual interest in the last 1 month and 10% had in the last 6 months. This was followed by inability to reach orgasm. 14% of women experienced the last 1 month, while 4% of women experienced this in the last 6 months. Looking at the etiology of the sexual dysfunction, there is biological or medical cause such as diabetes, hypertension, hypothyroidism, and vaginitis, and so on. And there are surgical causes like mastectomy, colostomy, and prostatic surgery, and so on. The drugs that are notorious to cause sexual dysfunction include beta blockers, calcium channel blocker, SSRI, benzodiazepine, and antihistamines. Misuse substance, this is important because the alcohol, heroin, amphetamine, and MDMA, that is the methylene dioxy methamphetamine, which is a synthetic drug that alter mood and perception, and marijuana, the cannabinoid, and cocaine are responsible for the sexual dysfunction. The psychological cause can be negative body image, hypervigilance, and fear of being rejected, and various psychiatric disorder. The most common is depressive disorder, and The If you look at the sexual dysfunction classification, the sexual one is sexual desire disorder, that include hypoactive sexual desire and or sexual aversion. The sexual arousal disorder in the female sexual arousal disorder or in the male erectile disorder. The orgasmic disorder can be in female orgasmic disorder and male orgasmic disorder, and premature ejaculation is one of them. The sexual pain disorder can be dyspareunia, and that should not be due to general medical condition. For example, if there is some problem as a result of arthritis or some pelvic infection disease, that will not be considered a dyspareunia. Dyspareunia is basically a condition in which there is sexual pain occurred as a result of no other than general medical condition. Similarly, vaginismus is also not due to general medical condition. Sexual dysfunction due to general medical condition are there, and as I've discussed that pelvic infection disease or any other things can, urinary tract infection can lead to this. And other sexual disorder can be substance induced sexual dysfunction, and some of them cannot be classified or specified otherwise. The sexual desire disorder or hypoactive sexual desire is a condition in which there is persistently or recurrently deficient or absent sexual fantasies and desire for sexual activity, and not better accounted for by any other psychiatric disorder such as anxiety and depression, and not due to physiological effect of substance such as alcohol and other medications. The sexual aversion disorder are persistent or recurrent extreme aversion to and avoidance of all genital sexual contact with sexual partner. Now you can see that there are other sexual deviation disorder which are also known as paraphilic disorder in the latest classification of American Psychiatric Association, that is Diagnostic and Statistical Manual of Disease in its 5th version. There can be voyeurism, which means the person takes sexual gratification by watching or seeing sexual activity. And there can be in the exhibitionistic disorder in which the person try to take gratification by showing the genitalia. The other sexual disorder can be sexual masochism, in which the person take sexual gratification by giving pain to the partner, and it can be in the worst order, which is called sexual masochism. In masochism, the person take gratification by taking pain, while the sadism, the person has to take gratification by giving pain to the partner. And there can be pedophilia, in which there is sexual gratification as due to involvement with kids or pediatric population. The others are transvestism, in which the person have sexual gratification by wearing clothes of opposite sexes or utensil of opposite sexes. The arousal disorder can be male erectile disorder, which is persistent or recurrent inability to attain or to maintain an adequate erection until completion of the sexual activity. Or the arousal disorder in a female could be persistent and recurrent inability to attain or to maintain an adequate lubrication, swelling response of sexual excitement until completion of sexual activity. The sexual pain disorder can be in the form of dyspareunia, which refer to persistent or recurrent pain during sexual intercourse in women and associated with history of rape or childhood sexual abuse, especially in women. Pain on deep penetration strongly suggests pelvic pathology like endometriosis or ovarian cyst. It can also manifest in men, but uncommon, and it is usually associated with organic conditions such as herpes and prostatitis. The vaginismus refer to an inability to achieve intercourse due to involuntary spasm of outer third of vagina, usually part of the phobic response to penetration, especially made worse by an inexperienced partner. And it is associated with fear of pregnancy, relationship problem, or negative attitude towards sex. Post-traumatic sexual experiences, a strict moral upbringing in which sex is associated with feeling of guilt and sin. This is very common in our condition because generally the sexual activity is talked in our country as a something that is not encouraged, or this lead to feeling of guilt or sin. Bura kaam hai. Therefore, if you look at the Islamic aspect, the responsible sexual activity among spouses is considered as worship. Assessing sexual behavior and sexual dysfunction, it is important that in our part of the country we have to be start in such a way that the person should be confident, and also he should assure that confidentiality will be maintained, and history of sexual behavior, lifestyle, and associated factor must be taken into account while having comprehensive interview, which should be socio-culturally sensitive. The medical examination can be in the form of that one should rule the medical causes of sexual dysfunction, and the psychophysiological evaluation can be done, and a psychiatric disorder or substance use that should also be looked into, that can be cause of the problem. The management of sexual disorder, this is a multifactorial, that if you look at the aspects, there are social aspects, psychological aspect, and physical aspect, and this the treatment should also be in a team in which is comprising of the psychiatrists, gynecologists, cardiologists, and other general physician, and the nutritionist can also have a good role in that. And it can be multifaceted in the form of either desire problem, or pelvic problem, or orgasmic problem. And the treatment should be starting with non-pharmacological problem, especially in our country, sex education, because sex education, there are misconception among our youngsters, and even the doctors or medical staff is inadequately trained to treat these conditions. Therefore, general information regarding the healthy lifestyle and non-pharmacological intervention followed by hormonal or pharmacological therapy should be done. Now the treatment can be, first of all, people are reluctant to go for consultation, and they usually go to hakims. This may be because of the societal barrier as a result of a stigma, and there can be professional barrier because the medical professionals are not adequately trained. So, and there should be psychotherapy, that is non-pharmacological intervention. The patient and partner education is very important, and then assessing for medical problem or systemic illnesses, and then there should be structured sexual task, and then the sexual pharmacology, pharmacotherapy, and we can also use the sexual devices, or behavior modification can also be done, and the alternative medicine in the form of herbal therapy are also used in this part of the world. The modification of risk factors is important, especially if you emphasize weight control, healthy diet, and regular exercise. This can lead to good performance, good physiology, biochemistry, and psychological well-being, because this can lead to having endorphin, enkephalin, and BDNF, and so on, which are very important for normal functioning. And then addressing psychological issues, Then cognitive behavior therapy for desire or vaginismus, a clitoral therapy device for arousal and orgasm disorders, and the treatment of depression is important because in our country, 34% of the population is suffering from anxiety and depression, and if you treat that, generally the sexual activities and sexual performance is improved. Hormone replacement therapy in postmenopausal women can also be done. The general sexual therapy with initial emphasis on the ban on the copulation, that is intercourse, and then addressing fear to overcome the psychological issues, and the woman is helped to desensitize herself by sometimes inserting the finger in the vagina, and so that the sizes can be dilatation can be done in that. The sex therapy, the primary goal and strategy, that education about normal sexuality and resolving myths is very important. And then cognitively restructuring, that we have to change the cognition, that is fahm or samaj, regarding the sexual activity, and because sometimes they feel that it is something which is not desired. Actually, if you look at the Islamic view, responsible sexual activity has been considered as a worship. Removing pressure by creating performance anxiety, and proceed to mutual enjoyment activity. That is a part of the sexual activity by giving something which is useful for both the partners, and that making at ease the partner, and then systemic sensitization. The couple is made to make a hierarchy of feared situation in which the fear is removed and sexual activity is enhanced or encouraged. The pharmacological or medical device use, it may be helpful at adjunct to psychotherapy or alone. Now there are a number of medicine that's or medication or pharmacological products are available that include phosphodiesterase inhibitor, which include sildenafil, comes by the trade name of Viagra, and so on. And if you look at this, the sildenafil was marketed, and this has led to 10 times increase in the sale with the Pfizer company when it made. The injectable and transurethral prostaglandin are also available, and topical vasodilators are also used. The vacuum and constriction devices are also used for selected cases. The hormonal therapy in the form of using testosterone or estrogen should be done if we feel that and we assess that there is a decreased serum level of testosterone. And the other herbal products such as yohimbine, ginkgo biloba, and ginseng is widely used. They are available over the counter in our country. And then there is ejaculation inhibition, that is the Marston and Johnson technique. SSRIs such as selective serotonin reuptake inhibitor, paroxetine, although this is one of the side effects of the paroxetine, that it lead to retarded ejaculation, and sometimes it is used for premature ejaculation. Clomipramine can also be used for premature ejaculation. Monoamine oxidase inhibitor, tricyclic antidepressants, SSRI, antipsychotics, and other dopaminergic antagonists have been implicated in these cases. The prognosis of these sexual dysfunction varies with type of dysfunction. Generally, good prognostic factors can be when there is supportive partner or self-referral for treatment, and no comorbid medical disorder or substance use disorder. The bad prognostic factor may be in the form of lack of intimacy among the partner, substance use, particularly alcohol, and comorbidities such as medical and psychiatric condition, and adverse life events and stressors and negative attitude about sexualities are there. The recent advances regarding the sexual dysfunction, for erectile dysfunction, gene therapy that would deliver genes that produce protein that may result in improvement in erectile function but may take a long time for regulatory approval and public acceptance. The other form of therapy is stem cell therapy is also on the horizon of making improvement in sexual dysfunction. With this, I'll end my talk. Thank you very much for your attention and concentration, and Jazakallah khair. Please mind it that if you treat such pets with sincerity and evidence based, this will lead to not only very good effect on the sufferer but also on the partner as well as on the family as well as on the performance in workplace. Thank you very much. Assalamu alaikum.